Coming to another procedure, which is the best site for arterial cannulation and why? Recently we have discussed ABG. So, what is the best site for arterial cannulation? Radial artery. Why? Because it is superficial, easily palpable. Commonly used artery for ABG, radial artery. What are the indications of ABG? So, cardiac surgeries, neurosurgeries, thoracic surgeries, any case of ARDS, ECMO, everything are the indications of ABG. What are the modified LN tests we have discussed? So, cleanse the feet, occlude the both the ulnar and radial artery, just remove the ulnar artery after sometimes, you can re-establish the circulation. So, the ulnar artery is patent. So, this is the station 15. Okay. Radial, ulnar, femoral, brachial, dorsalis, superficial, temporal. So, mostly these are the artery used for the cannulations of the superficial arterial cannulations. Respiratory failure in acute and chronic states, any severe illness which leads to metabolic acidosis, for example, cardiac failure, liver failure, renal failure, hyperglycemic state, multi-organ sepsis, burn, poison, sleep studies. So, these are the causes of metabolic acidosis and causes of, and we can do ABG. LN test we have already discussed, so I don't want to discuss here. Coming to the annotations. Left upper canine tooth is dislodged during intubations in a 14-year-old girl. During an emergency appendectomy, the incident needs to be explained to the parents. So, it is always a medical legal case. How you begin conversation? There is no answer to these questions. There is no answer to this OSCE station. You write your own. I will start the conversation that I will very polite, I will very light in this way. What are the how you will explain? Sometimes there will be difficult intubation. So, to get a good view and to save the patient life, this incident might take place. What are the options you provide to the parents for further management? We can go for a teeth repair, or we can have a new teeth for that. What are the further applications you will suggest? So, see that the different medical legal and the consent like things, medical ethics like things, you have to answer if your own. No specific answer for these questions. Coming to the station again, 1, 2, 3 and 4, phase 0, figure 1, phase 1, phase 2, phase 3, phase 0, figure A, B and C. So, here you can say figure A is curare cleft, spontaneous respirations. Esophageal intubations. Mostly it is a rebreathing or see, this is more than 5, so rebreathing. Phase 1, phase 2, phase 3 we have discussed. This phase of bringing of inspiration, this is inspiratory peak, this is the inspiratory pause, and this is the started off. Again, so this is the starting of inspiration, this is alveolar gas plus dead space, this is a purely alveolar gas, and this is the starting of inspirations. Phase 1, phase 2, phase 3 and phase 4, okay. Okay, another stations, another equipment, Desflurane. Identify the device when this is a vaporizer. Desflurane vaporizer, so to say. MAC value 6, boiling point 24. Or 22.6, and with the two specific features for device. So, this is a blender. It is the blender. It will use another source of electrical current. So, this is the specific features. So, Desflurane vaporizer classified plain now, dual circuit and vapor glass blender, thermal compression by supplied heat and agent specific. These are the specific features of the Desflurane vaporizers. Okay, MAC is 6%, saturated vapor pressure is 666. First, the saturated vapor pressure of Desflurane near the atmosphere. Why this Desflurane requires a separate vaporizer? We have already discussed in the international chapter. Just to revise, because the saturated vapor pressure of the Desflurane is nearly equal to the atmospheric pressure, so it will having a higher amount of saturated vapor pressure. To produce a clinical relevant concentration, we require a very high fresh gas flow. So therefore, we require a separate vaporizer for that. So rate of evaporation will fall. Station 8. Identify the curve. This is ODC, oxygen dissociation curve. Point A, B and C in the curve. What happened to the oxygen delivery in the come to right? So when the curve changes to right, here right, increase in oxygen delivery. To the left, decrease in oxygen delivery. 3 causes towards the right, 3 causes towards the increase in CO2, increase in pH and decrease in PO2. What is the shape? Sigmoid. Because why? Because it is a sigmoid shape, because the one oxyhemoglobin binding will favor other oxyhemoglobin binding. So therefore, there will be a normal phenomenon. So therefore, it is a sigmoidal structure. Right side, increase in PCO2, increase in temperature, increase to the decrease in pH. Decrease in PCO2, decrease in pH, decrease to the temperature and fetal hemoglobin. Left side decrease oxygen delivery, right side increase oxygen delivery. Fine. Sigmoid, because one binding of oxygen molecule will another, again they will help to bind another oxygen molecule. So there will be a cooperative binding. So therefore cooperating binding, there will be sigmoid safe. Annotations. So here this what is the position surgical procedure it is used? Mostly it is a sitting position. Sitting position. For the neurosurgery cases. So to access certain structure in the brain, we assume this type of position. There is the most serious complications, venous AR embolism. And what are the two most sensitive method to detect? Most sensitive method to detect is this EtCO2, also a sensitive method. The precordial Doppler is also a sensitive method. We can also do echo, it is also a sensitive method. We can also do the EtCO2, it is a sensitive method. How will you manage these conditions? Sitting position, decrease in venous perfusions and lungs volume. Cardiac output and stroke volume definitely decrease. Decrease in ICP, so better surgical exposure in the brain surgeries. So and it will increase the venous drainage. So therefore the chances of cerebral edema and the oozing is also very less. Paradoxal AR embolism is very much dreaded complications of sitting position. Chances of pneumocephalus and pneumoventricle. Venous AR embolisms, it can have precordial Doppler, most sensitive. TE also we can use in the 76% of the patients. So the most sensitive parameters is TE, and the second thing is precordial Doppler. The rate of venous AR embolism is around 25% in cervical laminectomy, transverse and sigmoid sinus. Monitoring, having a high level of sensitivity, specific and rapid response. So TE and precordial Doppler. The combination of precordial Doppler and expired CO2 meets the criteria. TE is more sensitive than anything. So TE, precordial Doppler, and EtCO2. These are the marker for venous AR embolism to detect. Fine. So here you can see monitoring. So what are the things, venous AR embolism, what are the things will decrease? PaO2 will decrease, CO2 will decrease, EtCO2 will decrease, cardiac output will decrease, BP will decrease when we infuse air in the venous system. Doppler, we can easily get 18 nitrogen will definitely increase, pulmonary arterial pressure will increase, PaCO2 will increase, and CVP will increase, CO2 will increase, and also the respiratory or esophageal stethoscope we can easily detect through precordial Doppler. So these are the things increase, these are things will decrease. Signs, symptoms, no physiological change with TE and Doppler. So when you detect this embolism through TE and Doppler, there is hardly any physiological change. Modest physiological change, when we see EtCO2 will decrease or pulmonary arterial pressure will increase, so there will be modest physiological change. Clinically apparent changes, cardiac output and CVP will be definitely decreased, and cardiovascular collapse after some times. Management, to prevent further entry, notify the surgeon, flood the surgical field with completely volume, jugular compressions to prevent further entry, lower the hand, treat intravascular air, aspirate with right heart catheter, discontinue nitrous oxide because nitrous oxide will further increase the size of the air, FiO2 to 1, pressure supports and chest compressions. So these are the management. Clear? Station 18, in hospital cardiac arrest. 6-link AHA guidelines 2022 for CPR. After return of spontaneous circulation in a cardiac arrest patient, the patient is not following the command during continued management. What should be the next end of management? So target temperature monitoring is the answer here. What are the 5H and 5T we have already discussed in the CPR, ACLS guideline, BLS guideline, whatever we have discussed. There hypoxia, hypovolemia, acidosis, everything we have discussed, 5H and 5T. What are the 6-link added? So here patient satisfactions we have added. So what are the 6-link added to the AHA guidelines? Mostly it is recovery. If the patient after developing, we have that initial management and late management. Either the patient develops spontaneous circulations after being recovered from the CPR. And the patient and the brain function becomes deteriorated. So we do the target temperature monitoring. We have do a CT scan. We'll do a MRI. And what are the reversible causes of 5N and 5T? We have already discussed in the cardiac arrest chapter. So identify the vasculature from A to G. This is a circle of Willis. So you can anterior communicating artery, anterior cerebral artery, middle cerebral artery, internal carotid. This is the posterior communicating artery. This is the posterior cerebral artery. This is superior cerebral artery. These two vertebral arteries joins to form basilar artery. This is ICA. This is a pica, and this is the interspinal artery. Definitely a question will come in OSCE. Circle of Willis. Okay. Name the lesion. So it is aneurysm. What are the treatment options? Coiling and clipping. What are the 4 important anesthesia considerations? So here coiling, aneurysm, coiling, anesthesia management. So preoperative clinical grade of the hemorrhage, ECG, hyperglycemia with insulin, treat hypovolemia, treat electrolytes. So these are the preoperative assessment. Anesthesia techniques, prevent further rebleeding, maintain a particular cerebral perfusion pressure. So cerebral perfusion pressure is always equal to mean arterial pressure minus ICP. So we have to decrease the ICP and increase the mean arterial pressure to increase the CPP. Prevent intraoperative brain swelling by using different monitors. So there are different types of parameters or different types of interventions through which we can decrease the intraoperative brain swelling. Optimize systemic physiology and manage glycemia. Anticipate and manage crisis situations such as rupture aneurysm. Facilitate timely and smooth emergency and neurological assessment. Prevent postoperative pain and other complications, and patient immobility is crucial. Induction, prevent hyperthermia. In response to laryngoscopy, there is a sympathetic stimulation and the patient can further go into ICH. So ensure adequate depth, prevent hypotension and prevent hypotension and hypocarbia. There must have a arterial line. The jugular oximetry is must. EEG is must. Agent of choice, propofol, remifentanil, sevoflurane, remifentanil. Avoid ketamine because sometimes this ketamine can increase in ICP. So there will be relative decrease in cerebral perfusion pressure. Come to the NS stations. So mostly it is a ProSeal LMA. Which generation? Second generation. Mention all the sizes. Yes. Describe body weight criteria for cup volume of the size ProSeal. Name any 4 other supraglottic devices. So here you can see this is a mask size 1 4 ml, 1.2 7 ml, 2 10 ml, 2.5 14 ml, 3 20 ml, 4 30 ml, 5 40 ml, and 6 50 ml. 5 kilo, 5 to 10, 10 to 20, 20 to 30, 30 to 50, 50 to 70, 70 to 100, and more than 100. So the size and cup volume. Size and cup volume. So ProSeal LMA size 1 to 5 volume. So this is the mask. Okay, this is the airway tube. This is the airway tube. This is the drain tube. This is the inflation line with pilot balloon. This is the machine end. This is the patient end. This is the drain tube. Fine. So inflation line, pilot, airway tube, drain tube, mask. Special features to LMA. A location straps or introducer straps is present. So here you can see this introducer strap. So we can change by putting our index finger, we can change the directions. Eradication, deflation cuff deflator is available. So we can easily decluff. As because if it produces a higher seal pressure in the ProSeal, we can use this ProSeal LMA in the laparoscopic surgery in the pregnant females. In the in the obesity, so where a higher interthoracic pressure is used or higher airway pressure is used, we can use this ProSeal LMA. Come to NR station. This is the POCUS. We have discussed this image in POCUS. So here you can see this figure 1 and figure B. What sign does figure and this is a double track sign? What does it mean and which situation it is useful? So it is endotracheal intubation. This is the tube inside the trachea. So here you can the lateral view, also the tube in the trachea. Fine. What does it mean? The tube is present in the endotracheal in the trachea. In what situation it is useful? We can monitor the endotracheal tube placement, and in case of difficult airway, when you negotiate the tube into the trachea, we can easily see through the ultrasound. Also, in case of awake fiber optic intubations, also we can, by the help of ultrasound, we can easily see the tube is going to the trachea. So it is known as double track sign. When the trachea, when there will be oesophageal intubation, we get a double track sign. So here esophagus is completely collapsed. Here esophagus is not visible, and here when the patient is intubated with the trachea and endotracheal tube, they see clearly the trachea is visible. Here esophagus is completely collapsed, the trachea is visible. Okay, so it is known as double track sign. While performing an ultrasound procedure to obtain the vascular access, you see this image. Which procedure is being used? What view is this, short axis or long axis view? So obviously it is a short axis view. Identify the structure in which the vertical arrow is there, so it is IJV. Identify the axis, so it is artery, internal carotid artery, or the other applications of anesthesia. So you can see here, this is the IJV, this is the sternocleidomastoid, this is thyroid gland, and this is the common carotid artery. So here you can see the guide wire here. So it is used for the central venous access or ultrasound guided IJV cannulations. Fine. So it is a vascular ultrasound. Here you can clearly see this is IJV because it is collapsible, and here below there will be a pulsatile structure, rounded structure known as common carotid artery. Okay, coming to the another stations. 56-year-old male, see the weight is more than 110 kilo. So it is obesity. Height is 163. You have to calculate the BMI. Probable diagnosis based on the history. Schedule for knee arthroscopy. Has a history of snoring, daytime somnolence. So it is a patient of OSCE. Complete diagnosis based on the history only. We say this is OSCE. Stop being snoring, tiredness, observe pressure symptoms, and BMI more than 35 or more than 40. There will be airway involvement. There will be difficulty in neck mobility, and gender is female. Neck circumference, age, BMI, and gender. Risk stratification in stop brain questionnaire. Okay. This is ambu bag. Identify the equipment zone. This is the ambu bag. Name the parts A, B, C, and D. What are the two disadvantages? Because it is self-inflating bag. Okay. So these two disadvantages will definitely read. So this is the oxygen source, oxygen catheter. This is the reservoir bag. This is the source for attachment of the reservoir bag and oxygen tube. This is the self-inflating bag. Fine. So see, oxygen connected tubing, oxygen reservoir, inlet port, self-inflating bag, outlet port, face mask, face cushions, and pressure gauge. Disadvantage: potential for inconsistent tidal volume delivery, reliance on the operator's skill, risk of gastric insufflation and aspiration, limit long-term use capabilities. Fine. Name the device. It is bronchial blocker. What are the indications? Difficult airway where we not able to put the double element tube. In case of lung separation technique, so any lung separation technique, if you write the indication, then definitely it will correct. These are the indications. What are the indications of double element tubes? Are the indications of bronchial blocker. Enumerate two other devices. So again, DLT univent tubes are all the other devices which are used to achieve the one lung ventilations. What is the advantage of this device over the similar device? So here it can easily push on the difficult airway. We can also do the selective lung collapse through this bronchial blocker. We can also put this bronchial blocker when the patient is under tracheostomy, and we can easily convert this one lung ventilation to a single lung ventilation when we use bronchial blocker. Negative point is that we cannot do so much of suctioning. We cannot do that complete lungs collapse through this bronchial blocker because the diameter is very much less. Coming to the station 8, 38-year-old male, height 166, 167, 165, weight is 55, lung mass, scheduled for lung resection surgeries, chronic smoker, unable to climb 2 feet. So the lung, the cardiopulmonary reserve is very much less. Enumerate the 3 legs approach or 3 leg for pre-thoracotomy respiratory assessment. What is the size of DLT will you use? So this is 55 kg, more than 38 males and more than less than 170. So it is 37. 5 regional anesthesia technique for thoracotomy. So 3 leg approach, cardiac respiratory mechanics, FEV1, post-operative FEV1 should be more than 40%. Minimum mandatory ventilation, RV by TLC and FBC, BO2 max, star climbing test, exercise testing. We have done all this 3 leg approach in the respiratory chapter. Run parenchyma, DLC, PaO2 and PCO2. These are the 3 leg approach. So 3 leg approach, respiratory mechanics, cardiopulmonary exercise testing, and lung parenchymal functions. VATS. When we do VATS, what are the regional anesthesia techniques for thoracotomy? So we can go for a paravertebral block, we can go for a retrospanic block, we can go for a QL block. We can go for a tab block also. We can go for a serratus anterior block. We can go for a thoracolumbar epidural block. So these are the types of pain management. We can go for a patient control analgesia block whenever we are going for a thoracotomy. Thoracic epidural plus lumbar anesthesia, paravertebral block, retrospiny level block. A 26-year-old male, 50 kg, have given rocuronium bromide, 45 mg per intubations. Now we are not able to ventilate the patient or not intubate the patient with the drug of choice for immediate device, Sugammadex. 2 to 16 mg per kg body weight. What is the dose of these drugs? You administer 16 mg per kg body immediately. The patient can reverse the effect from the 6 seconds or 10 seconds. With the mechanism actions, they mostly engulf the rocuronium, and there will be a lipid-based solution. There will be a special site for the attachment rocuronium, and they will decrease the intravascular concentration of this rocuronium. So whatever the neuromuscular blocking drugs are present in the neuromuscular side, they will again come to the intravascular space and finally remove through the renal circulations. Most common side effect of the drugs, they mostly cause anaphylaxis or allergic reaction, and sometimes because of the renal insufficiency, so they are hardly to eliminate this type of drugs. Here is a history of hypersensitive reactions, skin reactions, creatinine clearance less than 30. 42-year-old male chronic smoker brought to the emergency department with sudden onset of breathlessness, chronic smoker, chest X-ray, spontaneous pneumothorax or ruptured bulla. Most probable diagnosis, it is the right-sided pneumothorax. 4 common clinical manifestations of this condition. So, tachypnea, tachycardia, hypoxia, hypercarbia, and also there will be decrease in the blood pressure. Immediate management, needle thoracotomy will do. Needle thoracotomy mostly done in the second intercostal space. What is the triangle of safety? Pectoralis major, latissimus dorsi, apex of the axilla and the fifth intercostal line in the anterior axial line. So, these are the triangle of safety. 14, 25-year-old male driving motorcycle at the speed of 90 km per hour at TA, GCS 6 by 15, pulse rate 110, BP 90 by 60, respirate 28. The patient have a severe head injury right now. What is the Lehman criteria? Look externally, evaluate 332, M for myopathetic reading, or for observed symptoms like breathlessness and all, or obstructed symptoms, and neck for neck mobility. So, this is the Lehman criteria we have discussed in the airway evaluations. Here they can also ask the question like, what is the ICP monitoring, how you drain this patient, how you ventilate the patients, how you decrease the ICP in this patient, what is the effect of hypercarbia in this patient, what is the drug of choice in this patient, how thiopentin decreases the ICP, why propofol is sometimes contraindicated, because here BP is 90 by 60, again you use propofol, so it will decrease the mean arterial pressure more than the ICP, so therefore the cerebral perfusion pressure will decrease. What is the role of mannitol in this patient, what are the drugs which control to ICP in this patient? So there are different types of questions that can be asked in this patient in these OSCE stations. Capnography, decrease, esophageal intubation. Immediate actions, remove the endotracheal tube and do immediate intubation. What phase of the capnography is the ATCO to read? It's phase 3. Technology behind the ATCO2 measurement, the spectroscopy and the chemical calorimetry. Name the 2 conditions in which there will rise in the baseline. So, rebreathing. So, here say the baseline is touching 0, so on the baseline touching 5, so that is the answer of rebreathing. ABG today we have discussed thoroughly. Calculate anion gap. Sodium, what is sodium? What is sodium? 138 minus sodium plus chloride minus sodium plus chloride plus sodium minus chloride plus bicarb. So what is the chloride? 113 plus what is the bicarb? It is around 10.4, 10.7. So 138 minus 120, so it is around 18. It is around 18. Normal reference of the anion gap, it is around 12 to 14. 2 examples of normal anion gap, so Mott piles. 2 examples of high anion gap, so high anion gap Mott piles, and normal anion gap mostly diarrhea. What is gap ratio? So change in anion gap by change in bicarb. We discuss ABG complete in our interpretation of ABG chapter. So please go through that, and ABG is very much vital. ABG will definitely ask in the exam what are the derived parameter, what are the observed parameters, everything is written. So anion gap, sodium minus chloride plus bicarb. What is the normal range? 10 to 12. Two examples of normal anion gap. So there are vomiting, diarrhea. These are the examples of normal anion gap. 2 examples of high anion gap metabolic acidosis. So Mott piles. What is the gap ratio? So gap change in anion gap by change in bicarb. So if the value is less than 1, so hagma plus nagma. If the value is 1 to 2, then it is only high anion gap metabolic acidosis. If the value is more than 2, then high anion gap metabolic acidosis plus metabolic alkalosis. Again ABG. Bilateral crepitations, pulse 128, respiratory 40, BP is 144, saturation is 93, 15 liters of oxygen. Type of respiratory failure. Okay. So here you can see PeO2 93, PeCO2 is 52, so it is type 2 respiratory failure. There is both presence and hypoxia and hypercarbia. Mention the key difference between type 1 and type 2. In case of type 1, there is only hypoxia. In case of type 2, there will be both hypoxia and hypercarbia. Describe the acid base status here. So you can see the pH is 7.1. PC2 is 52 and the bicarb is around 14. So here the bicarb is also decreased and the CO2 is also increased and pH is decreased. So it is both respiratory acidosis plus metabolic acidosis. Fine. With likely diagnosis, history of myocardial infusion admitted with growth-related breathlessness, severe respiratory distress, accessory muscles, JVPS, Belton. So congestive cardiac failure may be the congestive cardiac failure with pulmonary edema. So because of the congestive cardiac failure, the perfusion is not good. So the lactate level is rising. So lactate level rising is because of lactate level rising, the patient develop metabolic acidosis, and it's because as the pulmonary edema is there, so ventilation perfusion mismatch is there. So the patient developing respiratory acidosis. Cause of metabolic acid disturbance, yes, we already told, decrease in renal hypoperfusion or the renal perfusion, there will be increase in the lactate, and second thing, there will be increase in the fluid space in the lungs, so it will cause pulmonary edema, so therefore it will lead to respiratory acidosis. So this is all about OSCE. I think we have covered so much of OSCE in this slide, and these are very important for the exam. So all the best.